the hidden battle beneath prosperity. Two continents, two global powers, two regions that pride themselves on civilization, progress, freedom, and modernity. From the outside, the United States and Europe seem like the pinnacle of advancement. Skyscrapers pierce the clouds. Innovation powers economies. Medicine breaks boundaries. And yet, beneath all this wealth, beneath the surface of luxury and lifestyle, a hidden war rages on. A war not fought with guns or politics, but with pills, surgeries, missed appointments, and silent suffering. A war fought in hospitals, nursing homes, private bedrooms, and long-forgotten rural clinics. It's the war for health, the one most people never see until it's too late. It's the mother skipping a cancer screening because her insurance doesn't cover it. It's the father who can't walk to the bathroom anymore because diabetes has claimed his legs. It's the child drinking soda for breakfast because real food is a luxury in his neighborhood. It's the grandmother who waits 6 months for a diagnosis because the public hospital is overwhelmed. It's the young man lying in an emergency room in Boston, breathing through an oxygen mask because the system saw him as a customer, not a life. It's the old man in rural Poland, silently enduring chest pain because there's no doctor for miles. This is the quiet epidemic of our time, where being born in the right zip code or holding the right passport determines not just how well you live, but how long you survive. We don't talk about it enough, but we must, because while the United States and Europe both sit atop the world stage, their healthcare systems, policies, and outcomes could not be more different. And behind these differences lie stories. Real, raw, often heartbreaking. In the United States, medicine is innovation. Hospitals gleam with billion-dollar technology. Pharmaceutical breakthroughs make global headlines. But access? That's a different story. More than 27 million Americans live without health insurance. Millions more are underinsured. Healthcare isn't just about healing. It's a business model. Every decision, every visit, every diagnosis, every treatment is filtered through a layer of financial fear. Will my insurance cover this? How high is the deductible? Can I afford to survive? In Europe, things feel different. A woman in France walks into a clinic, gets screened, and walks out without paying a cent. An elderly man in Denmark receives weekly home visits from a nurse, not because he's rich, but because he's a citizen. Children in Sweden are taught healthy eating in school, while their lunches are subsidized by the government. In much of Europe, health is not just a service. It's a human right. But even Europe isn't immune to modern illnesses. Obesity is rising. Smoking still kills. Mental health systems are strained. Populations are aging faster than ever. Still, the difference lies in the response. Where the US often reacts to sickness, Europe tries to prevent it. Where the US puts choice in the hands of private companies, Europe puts care in the hands of public policy. And yet both systems are failing in different ways. Both struggle with chronic illness, aging populations, cancer, inequality, and lifestyle-driven disease. Both face growing pressure as their populations demand more and resources become strained. So this is not a tale of which is better. It's a story of contrast, a comparative mirror, showing how two giants handle the most basic need of all, the right to be healthy. This is the story of what happens when success hides suffering, when progress races ahead, but health is left behind. When we build empires of concrete and glass, but forget to care for the people who walk within them. This is the story of modern health, of the cracks in our systems, of the silent suffering behind our statistics, and of the urgent need to ask not just who has the best medicine, but who is using it to heal their people. Completely, equally, and without profit attached to every breath. Obesity and lifestyle-related diseases, a tale of two worlds. Close your eyes and imagine two scenes. In one, you see an American highway lined with fast food chains, giant sodas, deep-fried everything, drive-thrus at every corner. In the other, a European town square, where people sit at outdoor cafes, sipping water or espresso, meals served in small, balanced portions, often prepared fresh with seasonal ingredients. These aren't just lifestyle choices. They are symptoms of two entirely different systems. Systems that shape bodies, influence habits, and determine whether people live in vitality or wrestle daily with chronic diseases. Obesity is no longer just a condition, it's a public health crisis, a cultural phenomenon, and for many, a silent battle waged every day. And no country has felt its impact more deeply than the United States. In America, more than 4 in 10 adults are considered obese. That's over 40%. It's not just about weight. This epidemic is intimately tied to the soaring rates of heart disease, diabetes, high blood pressure, stroke, sleep apnea, certain cancers, and even mental health conditions like depression and anxiety. By comparison, many European nations still struggle with obesity, but their numbers are considerably lower. In Italy, for example, adult obesity sits below 20%. In France, it's around 17%. Even in Germany and the UK, which are seeing rising trends, the rates still fall short of America's. But why is this happening? Why is the United States, with its advanced healthcare systems and wealth of information, leading the world in a preventable crisis? Let's break this down. Because the root of the issue doesn't lie in one factor. It's a combination, a complex equation of food, culture, urban design, economy, and time. Reason 1, the fast food culture and dietary habits. America's food industry was built on convenience. Drive-thrus, microwave meals, sugar-laden snacks, these aren't occasional indulgences. For many families, they're staples. Portion sizes in the US are often double or even triple those in Europe. A single meal at an American restaurant can exceed a person's daily recommended intake for calories, sodium, and fat. Why? Because the food culture rewards value and volume over quality and nutrition. Contrast this with Europe's traditional diets. In Spain, the Mediterranean diet, rich in olive oil, fish, fruits, and vegetables, is not a trend, it's a way of life. In France, meals are often slower, more deliberate, with multiple courses and smaller portions. Food is social, not rushed. It's prepared fresh, not pulled from a plastic wrapper and heated in 90 seconds. The American food system is also saturated with added sugars and ultra-processed foods. Sodas, breakfast cereals, packaged snacks, they dominate grocery shelves. In fact, studies show that nearly 60% of the average American's caloric intake comes from ultra-processed foods. Compare that to Italy, where processed food consumption is less than 25%. This one difference alone translates into reduced inflammation, lower insulin resistance, and decreased rates of obesity-related disease. Reason 2, urban design and physical inactivity. Take a walk, literally. In many European cities, people walk to work, to school, to the store. Public transport is efficient, and cities are built with pedestrians in mind. In America, suburban sprawl, car dependency, and poor walkability have created a society that sits more than it moves. In Europe, it's not uncommon to take 10,000 steps a day just living your life. In the US, between office jobs, long commutes, and entertainment dominated by screens, the average is far lower. Sedentary lifestyles are now considered one of the leading contributors to chronic diseases, and America is one of the most sedentary nations in the developed world. Children, too, are affected. In the US, many schools have reduced physical education or recess time. In Europe, it's not unusual for kids to play outdoors for hours, walk to school, or engage in sports as a community activity, not just a privilege for those who can afford it. Reason 3, economic inequality and food deserts. In America, health is a class issue. Lower-income families often live in food deserts, areas where fresh produce is hard to find, but processed, cheap calories are everywhere. When the healthiest options are also the most expensive or least accessible, families are forced to choose what's available over what's ideal. In Europe, many countries subsidize healthier foods or regulate the marketing of junk food, especially to children. In the US, however, fast food is marketed aggressively, especially in communities of color and lower-income neighborhoods. The result? A cycle of poor nutrition, weight gain, and preventable illness that's passed down through generations. Reason 4, psychological and cultural factors. Obesity isn't just physical, it's emotional. Stress, anxiety, loneliness, all of these drive unhealthy eating habits. The American work culture, which often glorifies long hours and minimal vacation time, leads to burnout and emotional exhaustion. Food becomes comfort. Time for exercise, self-care, or cooking real meals becomes a luxury few can afford. Meanwhile, many European nations emphasize work-life balance, mental health support, and regular breaks, factors that indirectly contribute to better physical health. So, what are the solutions? Despite the grim numbers, this crisis is reversible, but it will take a multi-level approach: individual responsibility, corporate accountability, and systemic reform. Solution 1: nutritional education and reform. Education must begin early, teaching kids not just about the food pyramid, but how to read labels, prepare meals, and understand what their bodies truly need. Government incentives could be redirected to support local farmers and organic produce rather than subsidizing corn syrup and processed meats. Menus and packaging should carry transparent labels about sugar, calories, and artificial additives, empowering consumers to make informed choices. In Europe, food education is part of many school curriculums. In France, for example, students learn how to appreciate the taste and origin of their meals, not just scarf them down in 20 minutes. Solution 2: promoting active living through infrastructure. Cities should be designed for movement, not just for cars. More sidewalks, bike lanes, parks, and safe public spaces would encourage Americans to move more, sit less. Tax breaks for companies that implement workplace fitness programs, walking meetings, or subsidize gym memberships could help fight office-based sedentarism. In Copenhagen, over 60% of residents commute by bike, not because it's trendy, but because the city makes it safe and easy. That's infrastructure saving lives. Solution 3: healthcare access for prevention, not just treatment. Too often in the US, people see a doctor after they're already sick. Prevention is the missing link. Free or low-cost annual checkups, nutritionist services, and community-based fitness programs can serve as early intervention. If insurance covered cooking classes, gym memberships, and mental health care the way it covers surgeries and medication, the tide could begin to turn. In countries like Sweden or the Netherlands, preventive care is embedded in the system. You're encouraged to stay healthy, not just treated when you're ill. Solution 4: cultural shifts in perception of food and health. Perhaps the hardest change is cultural. In America, being busy is worn like a badge of honor. Fast food is normalized. Eating quickly, mindlessly, in your car between meetings is seen as efficiency. But health isn't just about efficiency, it's about intention. Europe's food cultures are slower, more mindful, and socially connected. Meals are an experience, not just fuel. The US needs a paradigm shift, one that doesn't glorify the hustle at the expense of health. This means creating space in society for people to rest, move, prepare food, and connect with others, essential human needs that technology and convenience have buried. Mental health challenges, a crisis in the shadows. In the quiet hours of the night, when cities go still and the noise of the world fades, millions of people across the United States and Europe lie awake, struggling not with illness of the body, but battles of the mind. These are the hidden wounds, the silent screams, the unseen bruises on the soul. Mental health, once whispered behind closed doors, is now the loudest unspoken epidemic of our time. And yet, how it is addressed on either side of the Atlantic reveals two vastly different approaches to healing, compassion, and support. Let's begin with the United States. A country of great innovation and resilience, but also one burdened by anxiety, depression, burnout, and emotional disconnection. More than 1 in 5 American adults, that's nearly 60 million people, experience mental illness in a given year. The statistics are staggering. Suicide rates have climbed by over 30% in the last 2 decades. Anxiety disorders affect nearly 40 million adults annually. Depression is now the leading cause of disability for people aged 15 to 44. And perhaps the most painful truth of all, most of them never get help. Compare this with Europe, where mental health issues are also rising, but where the approach to care, the access to treatment, and the societal attitudes are often more progressive, structured, and compassionate. But why such a divide? Why, in one of the richest nations on earth, do so many people suffer in silence? Why is therapy often seen as a luxury rather than a basic human need? Why do people turn to emergency rooms, police, or prisons instead of counselors, community centers, or prevention? Let's break it down. Reason 1: stigma and cultural conditioning. Mental illness does not discriminate. It strikes the wealthy and the poor, the young and the old, the CEO and the student. But how we talk about it, or avoid talking about it, shapes everything. In the United States, there remains a deeply rooted cultural stigma around mental health. Despite growing awareness, many still view mental illness as a personal failure, a weakness, or something to hide. Men are taught to man up. Women are often dismissed as emotional. Teenagers are told they're just going through a phase. The result? Shame, silence, suffering. In contrast, many European countries have made strides in normalizing mental health conversations. In Sweden, mental health days are accepted as valid reasons for absence. In Norway, children are taught emotional intelligence alongside academics. In Germany, therapy is often integrated into primary healthcare plans. These aren't just policy differences, they're reflections of cultural values. In Europe, mental well-being is increasingly seen as part of overall health. In the US, it's still often viewed as a separate and optional dimension. Reason 2. The cost of care and healthcare structure. In the US, access to mental health treatment is often determined by one thing: money. A single therapy session can cost anywhere from $100 to $250. Psychiatrists, especially those not covered by insurance, are even more expensive. And insurance? Even when available, it may not cover the full cost, or may limit the number of sessions allowed per year. Many therapists don't even accept insurance, driving patients to pay out of pocket or go without care. Now picture this. You're struggling to get out of bed. You can't concentrate, can't function, can barely breathe. And the first question you're asked is, do you have insurance? In Europe, where many countries offer universal healthcare, mental health services are often included in basic coverage. In France, a national health card can provide access to therapy for little to no cost. In the Netherlands, psychological services are integrated into general healthcare plans. And in Finland, schools offer mental health support starting at a young age. Affordability alone creates a massive divide in who gets help and who doesn't. Reason 3. Social isolation versus social infrastructure. Mental health doesn't exist in a vacuum. It's influenced by relationships, community, and connection. In the United States, the structure of modern life has created an epidemic of isolation. Urban sprawl, digital lives, high-pressure work cultures, and declining community engagement have left millions feeling alone, unsupported, and unseen. Social bonds are weakening. Families are fragmented. Friendships are reduced to likes and swipes. In Europe, particularly in southern and eastern regions, the concept of community remains stronger. Multi-generational households, communal meals, village life, and localized support systems still play a role in keeping people grounded and connected. While not immune to isolation, European societies often maintain more social infrastructure, the invisible web of care that supports mental well-being. Consider Portugal, where mental health is approached through both medical and social intervention, community centers, mobile units, family therapy. Or Denmark, which consistently ranks as one of the happiest countries in the world, thanks in part to its emphasis on balance, leisure, and mental wellness. Reason 4. Burnout and overwork culture. In America, the grind never stops. A 60-hour workweek is a badge of honor. Vacation days often go unused. People are judged by their productivity, not their peace. This culture of constant hustle feeds into skyrocketing rates of anxiety, depression, and burnout. The pandemic only intensified this, blurring boundaries between work and home, leading to what experts now call the new mental health pandemic. Europe, while certainly competitive, has stronger protections against burnout. In France, workers enjoy a 35-hour workweek and mandated paid holidays. In Germany, labor laws prevent overwork and protect mental rest. In Switzerland, employees have the legal right to disconnect from work emails after hours. The difference isn't laziness, it's balance. And balance is the bedrock of mental resilience. So, what can be done? America doesn't lack therapists, scientists, or tools. What it lacks is accessibility, infrastructure, and a cultural shift that truly prioritizes mental health. The good news? There are solutions, bold ones, human ones. Solution 1. Normalize and destigmatize mental health. The first battle is perception. Mental health needs to be spoken of the same way we speak of diabetes or asthma. Schools, workplaces, and families must engage in open dialogue without judgment, fear, or shame. Media campaigns, storytelling, and public figures sharing their own struggles can help dismantle stigma. In the UK, Prince William and Harry's mental health initiative opened floodgates for conversations long buried. The US can do the same, with real leadership and real empathy. Solution 2. Expand affordable, accessible treatment. Mental health care must be treated as a public health priority, not a private luxury. The U.S. government could invest in expanding Medicaid's mental health coverage, incentivize insurers to provide comprehensive therapy options, and fund telehealth programs for underserved areas. Sliding scale therapy models, school-based counseling, and training more professionals, especially in rural areas, can bridge the current care gap. In Italy, a national overhaul in the 1970s transformed mental health care from institutionalization to community care. America, too, can innovate. Solution 3. Rebuild community and support networks. Mental health isn't just a medical issue, it's a social one. Community centers, peer support groups, mentorship programs, and local outreach can provide crucial safety nets. Loneliness is a public health crisis, and connection is the cure. Faith-based initiatives, nonprofits, and neighborhood outreach can bring people together. Mental health begins not in clinics, but in the places we live, work, and gather. Solution 4. Reform work culture and protect rest. Workplaces must evolve. Mental health days should be as accepted as sick days. Flexible schedules, mandatory vacation policies, and in-office mental health resources can save lives. The U.S. should consider national labor protections for psychological safety. Just like physical safety, Europe offers a blueprint, and the blueprint works. Access to healthcare, the divide between privilege and policy. Imagine this. You're sick. You feel a pain you've never felt before. Sharp, unbearable, possibly dangerous. You're scared. You need help. Now imagine two realities. In one, you rush to the hospital, show your government-issued health card, and receive care immediately. No questions about your income, insurance, or employment. In the other, before you can even think about calling an ambulance, you pause and ask yourself, can I afford this? Will my insurance cover it? Will this visit bankrupt me? This is the chasm that separates access to healthcare in Europe and the United States of America. Two continents, two philosophies, two outcomes for the same human need, to be cared for when we are most vulnerable. The American healthcare reality. The United States is home to some of the most technologically advanced hospitals in the world. It boasts top-tier doctors, groundbreaking medical research, and cutting-edge procedures that attract patients from across the globe. And yet, over 27 million Americans are uninsured. Even more are underinsured, meaning they technically have coverage but still can't afford the care they need. In fact, medical debt is the leading cause of personal bankruptcy in America. And more than 1 in 3 Americans delay or avoid medical treatment, not because they fear a diagnosis, but because they fear the cost of survival. Healthcare in the U.S. is not just a service. It's a business. Hospitals charge thousands for emergency visits. Ambulances can cost more than a month's rent. Prescription drugs are often marked up tenfold compared to other countries. And insurance companies act as middlemen, deciding what's covered, what's denied, and who gets access to life-saving care. This is not a health system. This is a system of risk management, built not on compassion, but on contracts, copays, and fine print. The European healthcare model. Now cross the Atlantic. In Europe, the dominant model is universal healthcare, a system where medical care is not tied to employment or income, but to citizenship. In Norway, healthcare is publicly funded and accessible to all residents. In France, the government covers the majority of health expenses, doctor visits, surgeries, hospital stays, and even home care. In Germany, citizens are required to carry health insurance, but the system is nonprofit and heavily regulated. Even in the United Kingdom, despite its challenges, the National Health Service, NHS, ensures that no citizen is denied care based on ability to pay. This doesn't mean Europe's healthcare systems are perfect. Wait times exist, bureaucratic delays occur, and funding is an ongoing debate. But one thing is certain, Nobody in Europe goes bankrupt because they get sick. Nobody is forced to choose between groceries and insulin. Nobody avoids treatment because they fear the bill. Because healthcare is not treated as a product, it is treated as a right. Why this divide exists. To understand this disparity, we must examine the ideologies behind each system. The American system evolved in the shadow of capitalism, a belief in personal responsibility, free markets, and limited government. Healthcare was never nationalized because it was seen as a commodity, like housing or transportation. Employers became the primary providers of insurance. Private companies filled the gap, and over time, profit took precedence over patients. In Europe, particularly after World War II, nations rebuilt their societies with solidarity as a guiding principle. Healthcare was recognized not as a luxury for the privileged, but as a foundation for equality. Universal coverage became a moral commitment, not a market decision. These roots have shaped generations of policy, perception, and practice. The cost of inequality. But what does this mean in real terms? It means that in the United States, people with low income are less likely to receive preventive care, resulting in more advanced and expensive illnesses. Black and Latino communities face disproportionate barriers to access and higher mortality rates. Rural areas often lack basic healthcare infrastructure, with entire counties operating without hospitals or specialists. Mental health, dental care, and vision services are often excluded from standard insurance packages, leaving critical needs unmet. And it means that life expectancy in the U.S. is lower than in many European countries, despite spending nearly twice as much per capita on healthcare. That's right. More money, fewer results. Why? Because the system is fractured. It's not built for efficiency, equity, or simplicity. It's built for profit. What are the solutions? Fixing the healthcare access problem in the U.S. doesn't mean copying Europe entirely, but it does mean listening, learning, and evolving. Let's explore what real solutions could look like. Solution 1. Expand universal access. Step by step. Universal healthcare in the U.S. has long been a political third rail, but recent years have shifted the conversation. Policies like Medicare for All, public options, and state-based expansions could provide a roadmap for universal access without dismantling existing infrastructure overnight. Look to Massachusetts, where near-universal coverage was achieved through a combination of mandates, subsidies, and insurance exchanges. Or California, which is exploring single-payer systems at the state level. These aren't just political gestures. They're life-saving policies. Solution 2. Cap prescription drug prices. Americans pay 2 to 10 times more for medications than people in Europe. Why? Because in the US, drug companies are allowed to set their own prices. In Europe, governments negotiate prices on behalf of the public, ensuring fairness and access. By empowering Medicare to negotiate prices, introducing price caps, and banning pay-for-delay tactics by pharmaceutical companies, the U.S. could immediately lower costs and expand access. Solution 3. Integrate public and private systems. A hybrid system, like those in Germany, Switzerland, or the Netherlands, offers a compelling model. In these countries, private insurance exists, but it is heavily regulated, non-profit by law, and must cover a standard basket of services. The result? Choice and competition without chaos, access and affordability without sacrificing innovation. America could adapt such a model, preserving individual freedoms while ensuring universal access. Solution 4. Make preventive care a priority. Too often, American healthcare focuses on treating illness after it develops, rather than preventing it in the first place. Europe excels in public health campaigns, free vaccinations, routine cancer screenings, nationwide education on diet, exercise, and mental well-being. That's all. Preventive care reduces long-term costs and improves quality of life. But in the U.S., it's often underutilized, underfunded, and overlooked. By shifting the focus toward community health, nutrition, early intervention, and chronic disease prevention, the U.S. could alleviate pressure on hospitals and improve health outcomes nationwide. Chronic diseases in aging populations, the weight of time. It doesn't happen all at once. First, it's just a little stiffness in the knees. Then, blood pressure numbers that inch upward each year. Later, a heart murmur, a prescription pill, a reminder to check blood sugar. A name forgotten here, a doctor's appointment rescheduled there. And then suddenly, the body becomes a calendar of survival. This is the story of chronic diseases. This is the long war of aging. Not dramatic like a heart attack, not as visible as cancer, but slow, grinding, ever-present, and everywhere. Today, both the United States and Europe face an escalating health crisis, not driven by outbreaks or pandemics, but by time itself. Populations are aging, bodies are weakening, and health systems built decades ago are straining under the weight. The question is not whether this crisis is coming. It's already here. The real question is, how are we dealing with it? The numbers don't whisper, they scream. In the United States, 60% of adults live with at least one chronic illness, such as heart disease, diabetes, arthritis, or hypertension. 4 in 10 adults have 2 or more chronic diseases. 85% of healthcare costs are consumed by these long-term conditions. The elderly population, 65 plus, is projected to nearly double by 2060. In Europe, about 50 million people live with chronic diseases. The share of the population over age 65 already exceeds 20% in countries like Italy, Greece, and Germany. By 2050, nearly 1/3 of Europeans will be 65 or older. This isn't just a health challenge, it's a demographic transformation. Chronic disease is the new normal. And aging is the backdrop against which all modern health systems must now perform. But how they perform, that's where the differences lie. Reason 1, aging populations, different priorities. In Europe, aging is seen as a societal responsibility. Countries like Sweden, Norway, and the Netherlands have long invested in universal pensions, home care services, social programs to keep seniors active and connected, government-funded long-term care insurance. Elderly citizens aren't just patients, they're protected. Compare that to the United States, where aging often means skyrocketing healthcare costs, isolation, patchwork care networks, and navigating Medicare gaps with limited support. Long-term care in the U.S. is often privatized and expensive. Nursing homes can cost over $100,000 per year. Home care is inconsistent and often underpaid. Many elderly rely on family members, who themselves sacrifice income and careers. Here, aging is a private burden. In Europe, it's a public responsibility. Fit. Reason 2, fragmented chronic care versus integrated support. In the United States, managing a chronic disease often means juggling a primary care doctor, a cardiologist, an endocrinologist, a physical therapist, a pharmacy, and countless bills, apps, and insurance claims. The system is fragmented, disconnected, exhausting. Each provider works in a silo. Medical records don't always transfer. And patients, especially elderly ones, must coordinate their own care like overworked case managers. Europe has taken a different path. In Germany, for instance, chronic care is coordinated. Primary doctors act as gatekeepers and care coordinators. Health insurers are nonprofit and must cover chronic disease management programs. Patients are enrolled in structured treatment programs with reminders, checkups, and outcome tracking. In Finland, electronic health records are unified nationally. In France, patients with long-term conditions receive 100% coverage for related care. No copays, no denials. In Europe, managing chronic disease is not just about surviving, it's about living better. Reason 3, physical decline and the hidden crisis of cognitive aging. Chronic illness isn't always visible, and the cruelest declines are often the quietest, in the mind. Alzheimer's disease, dementia, Parkinson's, and other cognitive conditions are rising rapidly. In the United States, over 6 million Americans are living with Alzheimer's. By 2050, that number will double. Care costs exceed $350 billion per year. Yet, most caregivers are unpaid family members. Support programs vary widely by state. Mental decline is still heavily stigmatized. In Europe, Scotland offers every newly diagnosed dementia patient a year of one-on-one support. The Netherlands has dementia-friendly communities with signs, social spaces, and trained workers. Spain, France, and Sweden invest in national dementia strategies with funding for research, caregivers, and public education. Europe doesn't just treat dementia as a disease, it treats it as a shared human journey. Reason 4, lifestyle prevention and the roots of disease. Most chronic illnesses, heart disease, type 2 diabetes, stroke, are preventable. They're born of poor diet, inactivity, smoking, alcohol abuse, and socioeconomic stress. In the US, the reactive model of care dominates. Treat the illness after it appears, prescribe medication, schedule follow-ups. In Europe, there is a stronger preventive culture. In Italy, walking is still a daily activity. In France, school lunches are balanced, cooked by chefs, and include education on nutrition. In Denmark, companies subsidize cycling and workplace wellness. And many European countries invest in early intervention programs, annual health checkups, subsidized fitness programs for seniors, food subsidies for low-income families, taxes on sugary drinks. America waits until the illness takes hold. Europe tries to stop it before it starts. Solutions: aging with dignity, not despair. The challenge of aging and chronic illness is not insurmountable, but it demands courage and compassion from policymakers, doctors, families, and all of us. Here are concrete solutions that can help both the US and Europe build a better path forward. 1. Build integrated care teams for every chronic patient. Nurses, doctors, dietitians, mental health providers, all on the same page. Assigned care navigators for elderly and vulnerable patients. Incentives for coordination, not competition. 2. Expand home care and aging-in-place programs. Invest in trained home health aides. Subsidize home modifications, rails, ramps, safety features. Offer stipends and paid leave for family caregivers. Make it easier and more dignified to age at home. 3. Double down on prevention. Universal access to nutrition counseling, exercise programs, and annual screenings. Subsidize healthy food, not junk. Tax sugar, regulate salt, ban junk food ads aimed at kids. Treat lifestyle medicine as a public priority. 4. Prioritize mental and cognitive health in aging. Early dementia screenings, public awareness to reduce stigma, respite services for caregivers, dementia-friendly infrastructure, signage, safe zones, supportive communities. 5. Digitize, connect, and simplify. Create one national health record per person. Make health data accessible across providers. Use AI and digital tools for reminders, alerts, and trends. Reduce bureaucracy and paperwork that confuse and delay care. Chronic disease and aging are not failures. They are a natural part of life, if we let them be. But in too many systems, they are treated as burdens. They are rushed, neglected, and pushed aside. We must reject that. Because how we treat our elderly and how we manage our chronic illness population reflects our values at the deepest level. To age with health is to age with dignity, and that is the future we must fight for. Cancer rates and mortality, a tale of two battles. It always begins the same way: a quiet room, the slow tick of a clock, a doctor staring at the chart a moment longer than usual, and then the words that turn worlds upside down. You have cancer. For that one soul, and for the family standing behind them, time fractures. The air gets heavier, life rewinds and fast forwards all at once. Memories, regrets, questions, everything collides. But beneath the swirl of panic, one question cuts through it all. Will I survive? And the answer to that question, tragically, unjustly, too often depends not just on the kind of cancer you have or how early it was caught, but where you live. In the United States or in Europe. Cancer, the unforgiving equalizer, yet a biased killer. Cancer doesn't care about borders. It doesn't care about politics, religion, or nationality. It's one of the greatest equalizers in theory, but in practice, it becomes one of the most biased killers of our time. In the United States, 1.9 million new cancer cases are diagnosed each year. Cancer is the second leading cause of death, just behind heart disease. Despite medical innovation, hundreds of thousands die, not always because the disease was unstoppable, but because the system was. In Europe, around 3.7 million people are diagnosed each year, and yet some nations have far lower mortality rates, even with smaller healthcare budgets. How is that possible? The answer lies in how care is delivered, when it starts, and who it's truly built for. This is not just about who has better doctors or more hospitals. This is about design, equity and access. Reason 1. Timing is everything. Early detection versus delayed diagnosis. Cancer is not always fatal if it's caught early, and herein lies the first divide. In the US, early detection depends heavily on insurance coverage, geographic location, awareness, and whether someone can afford to take a day off work. Many cancers, breast, cervical, colorectal, are highly treatable in early stages. But millions of Americans delay or skip screenings because they don't have insurance, they fear medical bills, or they simply lack access to a regular doctor. Contrast that with Europe. In countries like Sweden, France, and the Netherlands, national screening programs send automatic invitations to citizens. Mammograms, pap smears, colonoscopies, all covered. Participation rates are tracked and improved through public health outreach. This is the power of prevention over reaction. Europe catches the fire when it's small. America waits until the house is already burning, and by then it's often too late. Reason 2. The crushing weight of cost. In the United States, the cost of cancer care is staggering, even for those with insurance. Deductibles can reach $10,000 or more. Medications may require copays of hundreds each month, and not every treatment is covered by every plan. For the uninsured or underinsured, the diagnosis can feel like a death sentence, not from the disease, but from bankruptcy. Families are forced to choose between life-saving treatments or putting food on the table, crowdfund for chemotherapy, or worse, walk away from care entirely. Now step into Germany or Denmark or Italy. There, a cancer diagnosis doesn't spark financial ruin because treatment is covered, because health is seen not as a commodity, but as a human right. Survival shouldn't depend on your wallet, and yet in the US, it too often does. Reason 3. Centralized public care versus competitive private markets. In many European countries, cancer care is coordinated through national cancer plans, public hospitals, specialist networks. There's consistency, oversight, and centralization. Patients are often referred directly to specialized cancer centers where their case is reviewed by multidisciplinary teams. Treatments are standardized. Access is not determined by income or insurance plan. In the United States, the system is fragmented. Hospitals compete. Specialists operate independently. Patients must navigate a maze of referrals, approvals, billing departments, and pharmaceutical companies. A cancer patient becomes a project manager, juggling insurance authorizations, out-of-network fears, and conflicting medical advice. And in that chaos, time is lost. And in cancer, time is everything. Reason 4. Racial, rural, and class-based inequities. In the US, your race, zip code, and income are powerful predictors of how or whether you'll survive cancer. Black Americans, for example, have higher mortality rates for breast, colorectal, and prostate cancers, are less likely to receive timely, guideline-based treatment, face systemic barriers from diagnosis to palliative care. Latino, indigenous, and rural populations also struggle, not from biology, but from neglect, lack of nearby clinics, language barriers, distrust from decades of discrimination. In Europe, while disparities still exist, universal healthcare reduces the gaps. A poor person in Finland gets the same chemotherapy as a rich one. A migrant in Spain still receives cancer screening. It's not perfect, but it is more fair. In America, health is too often a reflection of privilege. In Europe, it remains a matter of policy. Solutions: rewriting the cancer story. We cannot rewrite a diagnosis, but we can rewrite what happens next. Here are the steps that nations, especially the United States, can take to move from profit to protection, from reaction to prevention, from inequality to humanity. 1. Universal, free, and mandatory cancer screenings. Make breast, cervical, colorectal, and lung screenings mandatory for at-risk populations. Cover them fully, with no copay. Automate reminders, track participation, and close follow-up loops. Launch national education campaigns to raise awareness. Cap out-of-pocket costs and eliminate insurance barriers. Set national limits on out-of-pocket cancer expenses. Cover all guideline-approved treatments under public and private insurance. Ban prior authorization delays for life-saving drugs. Penalize insurers who deny timely care. Hammer 3. Create national cancer navigation programs. Train and assign nurse navigators to all cancer patients. Provide language services, transportation, financial aid, and mental health support. Especially expand these programs in underserved rural and urban areas. 4. Invest in equity-focused research and outreach. Fund studies on cancer disparities. Bring screening and treatment to rural and minority communities through mobile units and telehealth. Build trust with culturally competent care. 5. Integrate cancer care into a public health framework. Learn from Europe's national cancer strategies. Standardize care, centralize data, and build multidisciplinary treatment centers. Stop letting hospital profits drive treatment plans. Start letting patient outcomes lead the way. Cancer is a human story, one told through hospital beds and treatment rooms, through tears and triumphs. It is not just a diagnosis, it is a mirror, showing us who we are as a society and who we choose to protect. Let me know if you'd like to continue with a full combined script, including all key points. Obesity and lifestyle-related illnesses, a silent epidemic. It begins subtly, a skipped walk, a fast meal between meetings, a few extra pounds that cling tighter each year. Then the blood pressure climbs, the knees ache, the doctor frowns at your blood sugar. And just like that, you've become part of a rising tide that is sweeping across the world. Not with the violence of a virus, but with the slow, suffocating grip of lifestyle-related illness. Obesity, type 2 diabetes, hypertension, heart disease, non-alcoholic fatty liver. These are the modern plagues, not born of microbes, but of modern life itself. And no two regions are fighting this battle more fiercely than the United States and Europe. Two societies built on abundance, now paying the price for excess. But while both struggle with rising waistlines and collapsing health, the roots of the crisis and the responses to it are often worlds apart. Let's take a closer look. The numbers tell a grim story. In the United States, over 42% of adults are classified as obese. Another 30% are overweight. Childhood obesity has tripled in the past 30 years. Nearly 1 in 10 Americans has type 2 diabetes. Cardiovascular disease remains the leading cause of death, with poor diet as a top contributor. Europe, while historically slimmer, is catching up fast. Obesity rates in the UK have surpassed 28%. In Germany, nearly 2/3 of men are overweight. Southern Europe, once home to the Mediterranean diet, now sees rising fast food consumption and sedentary behavior in youth. This isn't about vanity. This is about survival. Because obesity doesn't just slow people down, it cripples organs, shortens lives, and drains national economies. Reason 1, the American food environment, a culture of convenience. In the United States, the food system is a trap dressed as freedom. Everywhere you look, dollar menus, supersized portions, ultra-processed snacks, sugary drinks the size of a liter, 24/7 delivery apps that bring salt and sugar to your doorstep. Fast food is cheaper than fresh produce. Gas stations sell more calories than grocery stores in some rural areas. Public schools serve highly processed lunches. Advertising for soda, chips, and candy targets children as early as age 2. In Europe, while the Western diet has made dangerous inroads, many countries have retained some nutritional sanity. France regulates portion sizes and bans vending machines in schools. Italy and Greece, despite economic hardship, maintain traditional diets rooted in vegetables, legumes, olive oil, and fish. Scandinavian countries limit junk food advertising during children's programming. The result, a slower rate of obesity rise and more nutritional awareness embedded in the culture. Reason 2, sedentary lifestyles and urban design. It's not just what we eat, it's how we move, or rather, how little we do. In the United States, entire cities are built around car dependency. Sidewalks are rare in suburban sprawl. Public transport is underfunded. Kids ride in cars even for trips 2 blocks away. Work involves desks, screens, and meetings, not motion. Contrast that with many European cities. In Copenhagen and Amsterdam, over 50% of people commute by bicycle. In Paris, walking is a way of life. In Barcelona, urban design promotes outdoor activity with parks, wide boulevards, and superblocks that limit cars. Movement is built into daily life, not carved out with gym memberships, but woven into routine. and that makes all the difference. Reason 3, health inequality and economic divide. Obesity is not just a matter of willpower. It is deeply tied to poverty, education, and access. In the US, low-income neighborhoods are often food deserts, places with few supermarkets, no farmers markets, and a high concentration of convenience stores and fast food chains. Healthy food is more expensive, less convenient, less available. This creates a vicious cycle. Poor diet, weight gain, chronic illness, lost wages, deeper poverty, even worse diet. In Europe, many countries have stronger social safety nets, government subsidies for fruit and vegetable programs, free or low-cost school lunches made from whole foods, nutritional education starting in kindergarten, access to health coaches or public gyms. While inequality still exists in Europe, the floor is higher. No child in Finland goes without a nutritious lunch. No elderly person in Sweden is left to survive on canned pasta and white bread. Reason 4, marketing, media, and misinformation. In America, corporations spend billions on marketing food that makes people sick, and virtually nothing on food that heals. Kids grow up watching cartoons sponsored by cereal companies. Energy drinks are glorified in sports. Healthy snacks are loaded with sugar and labeled low-fat to trick the public. And influencers now promote diet pills and fast fixes instead of nutrition and balance. Europe, while not immune, is more protective in many regions. The UK restricts junk food ads before 9 p.m. Norway bans ads aimed at children under 12. France requires warning labels on food ads similar to cigarette packaging. Avoid eating too much fat, sugar, or salt. In the war for public health, information is ammunition, and misinformation is a weapon turned inward. Solutions turning the tide on lifestyle disease. This crisis is not inevitable. It is not unchangeable. It is a byproduct of choices made by governments, businesses, and communities, and those choices can change. Solution 1. Regulate the food industry like tobacco. The same playbook that curbed smoking can be applied to food. Tax sugary drinks and processed snacks. Ban junk food marketing to children. Require clear front-of-package labeling. Subsidize whole foods like fruits, vegetables, legumes, and grains. Countries like Mexico implemented a soda tax and saw consumption drop significantly within a year. Hungary taxed high-sugar foods and used the revenue for public health campaigns. America and even parts of Europe can follow this path. Solution 2. Redesign cities for movement. If we want people to move, we must make it easy and beautiful. That means build more parks and bike paths. Widen sidewalks. Encourage public transport. Turn schoolyards into community fitness hubs. Support walkable neighborhoods, not strip malls. Europe's cycling and walking culture didn't happen by accident. It was the result of deliberate investment in active infrastructure. The US can't rely on gyms and apps alone. It must rebuild its cities to move the body, not just the car. Solution 3. Educate early. Feed smart. Habits form in childhood, and they last a lifetime. America must adopt a national plan to teach nutrition and cooking skills in every school, ban sugary drinks in cafeterias, provide free meals based on whole food principles, involve parents through community workshops and incentives. Countries like Japan emphasize food culture as much as academic subjects and enjoy some of the lowest obesity rates in the world. Solution 4. Treat obesity like a chronic illness, not a moral failure. Obesity is not laziness. It's not gluttony. It's not stupidity. It is a disease, and it must be treated with science, compassion, and systemic tools. This includes expanding access to dietitians and health coaches, covering obesity treatment under public and private insurance, training primary care doctors to recognize and treat obesity without shame, supporting mental health services for emotional eating, trauma, and food addiction. In Portugal, obesity is treated within the public health system, with care teams that include psychologists, physicians, and nutritionists. The US can take a page from that book and stop blaming the patient for a system that sets them up to fail. The health of a nation is the soul of its people. So here we stand, at the edge of insight, looking into the hearts of two mighty lands. The United States, with its innovation, its ambition, its fierce independence, and Europe with its tradition, its solidarity, its quiet resilience. We have walked through the burning corridors of mental illness, the storm of chronic disease, the silent rise of lifestyle-related deaths, the fragile dignity of aging, and the cruel certainty of cancer and inequality. Each story a thread woven into a tapestry that reveals the truth of our time, that health is not just a medical issue, it is a reflection of how a society sees its people. In America, the brilliance of medicine shines like a beacon, if you can reach it. Doctors who can perform miracles, hospitals that look like space stations. But for millions, that brilliance never reaches their homes, because access has a price tag, and too many are left in the dark. In Europe, the care is quieter, slower perhaps, but more universal. There are flaws, no doubt. Bureaucracy, waiting lists, limited resources. But there is also a truth, that you are never alone when you are sick. And this is the great divide. It is not just about which continent has better hospitals. It's about which societies choose to see health as a right and which still treat it as a privilege. Because in the end, the health of a nation is not measured in machines, not in patents, not in insurance profits. It is measured in the mother who catches her cancer early because her screening was free. It is measured in the child who plays outside in a park, not stuck behind screens. It is measured in the elderly man who dies with dignity, not in isolation. It is measured in prevention, not just cure. In care, not just commerce. The USA and Europe have different strengths, but both must ask the same question now. What kind of future are we building if we can't protect the health of the very people who live in it? Because medicine can save a life, but systems built with justice, compassion, and equity, those save generations. And if we are bold enough to learn from one another, brave enough to rethink what health truly means, and human enough to put people over profit, then maybe, just maybe, we won't just live longer. We'll live better.